Classification of soft palate. Soft palate is classified into three classes as 1, 2 and 3. Class 1 indicates soft palate in which there is more amount of posterior palatal seal area. The relationship between the hard and the soft palate is more horizontal and there is minimum muscular activity. There is considerable separation between the anterior and posterior vibrating line, thereby increasing the space of the PPS area. Class 3, it is seen in conjunction with high V-shaped palatal vault and there is only few millimeter of space between the anterior and posterior vibrating line. Hence, there is small PPS area and least retention of the upper denture. Class 2 is a palatal contour that lies between class 1 and 3. Now, there are various techniques which are established for recording of the posterior palatal seal area. They are divided into the conventional approach and fluid wax technique. And we also have arbitrary technique in which an instrument is used or a burr is used for tentatively scraping the master cast before fabrication of the final denture. The rationale for placement of seal in the impression trays are as follows: to establish a positive contact posteriorly to prevent the final impression material from sliding down into the pharynx, and it serves as a guide for positioning the impression tray, especially if a shim has been used within the tray to establish the borders. It also creates slight displacement of the soft palate to determine if there is adequate retention and seal of the potential denture borders if present. In the conventional approach of recording posterior palatal seal, after the special tray is fabricated, there are certain instructions which are given to the patient. They are supposed to rinse their mouth with an astringent mouthwash that is used to remove the stringy saliva that might prevent clear transfer of PPS marking into the impression. Location of the pterygomaxillary notch is done by moving the T-burnisher posteriorly to the posterior angle from anterior region and just behind the maxillary tuberosity. When the operator feels a depression, that shows the location of the hamular notch. An indelible pencil is used for marking this hamular notch on either side, and then the patient is asked to say "ha" in a short burst for recording of the anterior vibrating line. The patient can also be used to perform Valsalva maneuver for recording of the anterior vibrating line. Indelible pencil is used for marking this and extended 3 to 4 mm anterolaterally from the tuberosity to the mucogingival junction. This joins the two extensions from the pterygomaxillary notch. Now, for the posterior palatal seal, indelible pencil is joined by connecting the line through the pterygomaxillary seal with the line just down the demarcation of the PPS area. The shellac or the special tray is then inserted into the mouth and seated firmly to place upon removal from the mouth. Now, this marking of the indelible lines which are done intraorally transfer onto the tray. Sometimes it might be necessary to redefine this transfer marking, and the tray has to be returned to the master cast to complete the transfer of the complete posterior area. The tray is then trimmed until the posterior vibrating line so that a decision on the posterior border extension is determined. Returning to the mouth, the palatal fissures are palpated with T-burnishers or mouth mirror to determine the compressibility of the PPS area. Termination of the glandular tissue usually coincides with the anterior vibrating line. The anterior vibrating line is then transferred to the master cast, this transferring the outline of posterior palatal seal. This is the picture which shows you how T-burnisher is used. There are two ends of the T-burnisher. One is the flat end, the other one is the ball end. The flat end is used for the marking the location of the hamular notch. The ball end is used for determining the compressibility of the posterior palatal seal area. For arbitrary method, the area is scraped to a depth of approximately 0.5 to 1 mm with the outline of the Cupid's bow, and the cast is scraped to depth of half among the palatal tissue so that the area can be compressed and used for utilization of the posterior palatal seal. Failure to taper this seal, the posterior area might lead to tissue irritation. The advantages are this trial base becomes more retentive, thereby It is helpful while recording the maxillomandibular relationship. By this way, the patient experiences more retention of the upper denture and increases the psychological comfort of the patient. The practitioner also is able to determine the retentive qualities of the finished denture. The new denture wearers will be able to realize the posterior extension of the prosthesis. The limitations are, however, it is not a physiologic method and therefore it depends upon accurate transfer of the vibrating lines and careful scraping of the cast. There are potential chances of over damming or post damming of the tissues in this area. Moving on to the fluid wax technique, for as the name indicates, the fluid waxes are employed and painted on. There are 4 fluid waxes: Adaptol wax, HL physiologic paste, Iowa wax and Correcta wax number 4, which can be used by painting the molten mouth temperature wax on the posterior palatal seal area after the impression is being recorded with the zinc oxide eugenol impression paste. And then once the mouth temperature wax is painted onto the PPS area, the patient is instructed to put the head at the 45 degrees to the Frankfurt's horizontal plane, so that the soft palate is in the inferior most position. The patient is asked to place the head at 30 degrees so that the soft palate is in inferior most position, and then the impression is recorded.